Hello. Our topic today will be about cough, hiccups, and secretions in the palliative care setting. I would like to start with a quote from Sir William Osler. If you listen to your patients carefully, they will tell you their diagnosis. Objectives, we're going to be covering three topics here today: cough, hiccups, and respiratory secretions. We'll start with the cough. Cough is a natural mechanism that protects the respiratory tract with multiple roles, such as important defense mechanism that clears secretions of foreign body from airways, important factor of infection spreading, a life-saving mechanism when keeping patient conscious during a potentially lethal arrhythmia or converting back to the normal cardiac rhythm. One of the most common symptoms for which patients visit a healthcare provider. Chronic cough is a distressing symptom, present in approximately 37% of patients with advanced cancer. Approximately 38% of these patients will rate the symptom from moderate to severe. Persistent and chronic cough can impact the lives of patients and their families. It can cause insomnia, fatigue, vomiting, worsening of pain, and anxiety. Physiology of cough. Cough can be a voluntary act or spontaneous reflex. Sensory nerves from larynx, pharynx, and upper respiratory tract join the vagus nerve and then enter the nerve system near the respiratory center, terminating in the medullary cough center. Phases of cough. We have different phases of cough. The first one is what we call the receptorial phase. When the cough receptors got irritated, this is basically the receptorial phase, followed by the inspiratory phase, which consists of contraction of the arytenoid cartilage resulting in glottis opening with rapid inhalation. This phase will require an average of 50% of the vital capacity with some variation depending on the stimulation. Following this is the compressive phase, happening with the closure of the glottis after the contraction of the adductor muscles of the arytenoid cartilage, which results in the adduction of the vocal cord. So it closes basically the opening. Expiratory phase is the final phase with action of abductor muscle of arytenoid cartilage, which causes sudden opening of the epiglottis and vocal cord, which basically causes explosive leakage of air to the outside, what we call basically cough, with complete exhalation and relaxation of the diaphragm. So this is the receptorial or irritation phase, followed by the inspiration, followed by the compression, and then expulsion. These are the nerves involved and the receptors, like TRPV1, the vanilloid receptors, TRPA1, RAR, which is basically the rapidly adapting receptor, and SAR, slowly adapting receptor. Okay, so these are explained here, right? The fibers that transmits these impulses are either A delta or C fibers. So it's a very complex reflex involving many centers in your brainstem, including the Bitzinger ventral respiratory group, and the cough center, the vagus nerve. Here, some of the centers we're talking about. All right. Pathogenesis. The ineffectiveness of cough reflex may occur when respiratory and laryngeal muscles are weakened or uncoordinated, decreasing the driving pressure, which will result in a low expiratory volume and flows during cough. Neuromuscular disease such as Parkinson's disease, multiple sclerosis, poliomyelitis, Guillain-Barré may have weakness or dysfunction of the respiratory muscle. The other important factor in effective cough is the tenacity of the mucus and the effectivity of the mucociliary transport system. The mucus needs to be dispersed into the expiratory gas. So there are two main factors affecting the cough itself: the muscles, the respiratory muscles, and the mucociliary system. And as I mentioned, these are the receptors involved in the process here, the vanilloid, the transient receptor potential, ankyrin, TRPA1, and others. The RAR and the SAR we just mentioned in the previous uh, slide here. Causes of cough. Cough could be caused by a different mechanism, like acid reflux. This is a very common problem, with people that having GERD, allergic reactions, flu, smoking, medications like ACE inhibitors, for example, bronchitis, postnasal drip from somebody that's having sinusitis, for example, asthma, and viral infections. So this is a summary to what I'm gonna show you in the next slides here. Here, cough can be complication of drug therapy, like ACE inhibitors. Um, the most common etiologies of chronic cough are upper airway cough syndrome or postnasal drip, previously called postnasal drip, asthma, GERD. So remember these three conditions, okay? Postnasal drip, asthma, and GERD. Other less common causes of cough include number of disorders of the airways, like non-asthmatic eosinophilic bronchitis, chronic bronchitis, bronchiectasis, neoplasm, foreign body, or interstitial lung disease or lung abscess. In the palliative care population, there are many malignant and non-malignant diseases related to chronic cough. For instance, cardiopulmonary source, such as tumor, asthma, infection, pulmonary edema, decompensated congestive heart failure, lymphadenopathy, or esophageal problems such as GERD, medications such as ACE inhibitor. An indirect cause could lead to infections such as pneumonia, bronchitis, empyema, and post-obstructive pneumonia. Fistulas from esophagus to respiratory tract in radiation to the chest can cause cough with swallowing in about 50% of the patients. Malignant diseases of lungs, pleura, airway, mediastinum, and metastatic to the thorax is another cause of cough. Types of cough. We have acute, which is basically less than 3 weeks, chronic, lasting from 3 to 8 weeks, and acute cough is mostly due to infection. Okay, Chronic cough is more often simultaneously due to more than one condition. As with other symptoms, a detailed history and physical remain the key to diagnose cough. Identifying important associated symptoms such as nausea, vomiting, uh, which will, point towards GI origin, insomnia, weight loss, lack of appetite. Uh, this will point to more of malignancy and cough characteristics and timing. Chest X-ray will always remain the main diagnostic tool in evaluating cough. There are some assessment tools that have been studied to evaluate cough, but these are more for a research type of deal. It's not something that we use on daily basis, like such as LCQ or Lister cough questionnaire. The other one is cough specific quality of life questionnaire, CQLQ. So if you're conducting research in this topic, you're probably gonna need one of these to capture your data. LCQ, and this is basically the LCQ. You have physiologic domain, physical domain, psychologic domain, and social domain. CQLQ, again, physical complaints, psychosocial, functional abilities, emotional well-being, extreme physical complaints, personal safety fears. Management studies, strategies. So first, stop offending agents. For example, ACE inhibitors. You can switch it to another type of medication like ARB for you. Resolution typically occurs within 1 to 4 weeks after the cessation of the therapy, but the cough may linger for up to 3 months. So be careful about this because you have to explain to the patient. It's not will stop. It's not like it will stop abruptly. It will take some time before it resolves, and it could be up to 3 months. You have also some home remedies for cough, like honey, lemon, mint tea, and ginger. Treatment of underlying disease. So for upper airway cough syndrome, you can use antihistaminics or decongestants. For asthma, use bronchodilators and or steroids. GERD, use PPIs. Inhaled sodium chromoglycate, there are only small randomized control trial from 96 for patients with lung cancer and chronic cough. So this is just some examples of the bronchodilators. This is the beta 2 agonist, Ventolin inhaler for salbutamol. The scientific name is salbutamol. And then you have the Fluvent or the fluticasone, which is the steroid that we use very frequently to treat asthma. Cromolyn sodium inhalation. Treatment of underlying disease could be done through radiotherapy or chemotherapy. Radiotherapy is useful in non-small lung cancer, and it improves the cough in 50% of the patients. While chemotherapy may also provide cough palliation, with studies showing 75% of patients achieving improvement of the cough. It is also important that dehydrated patients may need additional fluid to be able to effectively use an expectorant. Speech therapy and physical therapy have been shown to be useful in these situations with chronic cough. Pharmacologic therapies. When cough serves no useful purposes like cleaning the airway, the antitussive is used. When the therapy is directed to the symptom rather than the cause, a non-specific antitussive is employed. If the cough is performing a helpful function like bronchiectasis or cystic fibrosis, for instance, the pertussive can be employed to encourage the cough. So really, the way you treat the cough depends on whether it is beneficial or not beneficial to the patient. If the cough is beneficial, like you're getting all the secretions out by coughing, like in cases of bronchiectasis and cystic fibrosis, for example, then you actually want to encourage the cough process. While if it doesn't serve any purpose, then we need to suppress. Benzonatate is a type of a local anesthetic, topical local anesthetic that's used in these non uh, coughs that doesn't really help in anything basically. It's been used in cancer patients with opioid-resistant cough. Benzonatate presumably anesthetizes the stretch receptors in the lung and the pleura with the recommended dose of 100 to 200 milligrams 3 times a day. Benzonatate capsules. Opioids for cough. You can use, opioids for cough. Most famous example is morphine. Codeine was widely used in the past. Codeine is metabolized to morphine in the body. Unfortunately, codeine, there are like in 10% of the Caucasians cannot metabolize codeine. Dextromethorphan is an antitussive antagonist of the NMDA and is found in most of the over-the-counter cough syrups. It's not indicated for the treatment of chronic cough due to a limited evidence of efficacy. Hydrocodone is a codeine metabolite, can be alternative to morphine, and it's pretty well tolerated in advanced cancer patients who presented with greater than 50% improvement of their cough using hydrocodone 10 milligram a day. These are just examples. You have here the dextromethorphan. You have here the codeine. You have the hydrocodone. You have morphine sulfate solution. Gabapentinoids have been used in moderate to severe cough, unable to take opioids. So there is some evidence that they could be helpful in palliative setting here. In small doses, gabapentin, pregabalin. The gabapentin, I usually give, up to 300 milligram. Here, the Lyrica, 75 milligram. Thalidomide is a very important agent. It works as an anti-inflammatory medication, and it's very useful in patients with idiopathic pulmonary fibrosis. Guaifenesin is an expectorant that have shown to have very limited benefit in reducing the cough intensity and no benefit from the mucolytics. Thalidomide has caused a huge problem last century because has been used in pregnant ladies to treat morning sickness, and it caused, these congenital anomalies that you see on your right side, absence limbs, and all that stuff. It was a big issue in last century. So basically, thalidomide is contraindicated in pregnant patients. Mucolytics are expectorants, which means they facilitate the sputum elimination by breaking the polymer network of mucin or the DNA actin. This might help with the mucus clearance. Carbocysteine is a type of mucolytic with some benefits for patients with cough due to bronchitis, but no benefit for advanced cancer patients. Another type of a mucolytic is the recombinant DNase, which is now recommended by the American College of Chest Physicians in their 2006 guidelines for use in patients with cystic fibrosis. So you have carbocysteine and you have N-acetylcysteine. You can, use either of them. Approach to managing cough in palliative care population. This is just a summary. Assess with detailed history examination and one appropriate complementary test, which could be chest X-ray and spirometry. Stop ACE inhibitors. Consider smoking cessation. Consider benign causes of cough, such as GERD, asthma, and upper respiratory tract infection. Upper airway cough syndrome. Use antihistaminics or decongestants. Asthma, mostly respond to bronchodilators and inhaled steroids. GERD, give prokinetics, PPIs, and antacids. Consider disease-directed treatments such as chemotherapy, radiotherapy, inhaled sodium chromoglycate. These are the only one small randomized controlled trial from 1996 with lung cancer and chronic cough. Prescribe an opioid, gabapentoid. If the patient has a very poor prognosis, consider cough suppression with opioid alone. Okay, so we'll jump into the next topic here, which is hiccups. And hiccups or singulatus is basically a synchronous repetitive spasm, myoclonic jerk of one of both hemidiaphragm and inspiratory intercostal muscles, with inhibition of the expiratory component of the latter, which is basically the intercostal muscle. As soon as the contraction starts, sudden closure of the glottis produces the characteristic sound and sensation. Most of the hiccups are benign, but it can last longer, okay, being described as persistent when lasting more than 48 hours or intractable after 1 month. The incidence of the symptom in advanced cancer patients is 1 to 9%. Basic physiology here. There is an article by Howes suggested that hiccups may have evolved along other reflexes developed in mammals that allow them to coordinate suckling milk and breeding. The afferent component is the vagus and the phrenic nerve and the pharyngeal branch of glossopharyngeal. The central mediation is thought to be located to the hypothalamus and the brain stem near the respiratory center. The efferent pathway of the arc is mediated by the phrenic and intercostal nerves. Serious hiccups are not unusual in cancer patients. Approximately 4% will have a chronic hiccups. Cisplatinum is a common chemotherapy that produces hiccups. Approximately 20% of the Parkinson patients have hiccups. Primary neurotransmitters are the dopamine and the GABA. And this is pretty important because, when we're talking about the management, you will kind of understand the importance of knowing these neurotransmitters. Uh, there are central and peripheral causes of hiccups. Brainstem strokes, infarcts, tumors, inflammation will produce hiccups. Tumor infiltration of the diaphragm, esophagus, or stenting of the esophageal obstructing lesion in the esophagus can cause persistent or intractable hiccups. Initial treatment involves treating any reversible cause and removing certain offending medications, such as corticosteroids and azithromycin, for example. Hiccups. There are spasm of the diaphragm and spasmodic closure of the glottis, irritation to the diaphragm or phrenic nerve. As you can see in the picture here, this is basically the hiccup. Causes of hiccups. Uh, Multiple causes: gastritis, gastric distension, bowel obstruction, hernias, diaphragmatic hernia, brainstem infarction, MS, cerebrovascular, Parkinson, neurosyphilis, epilepsy, uremia, steroids, sepsis, electrolyte imbalance, ENT infection, grief, anorexia, personality disorder, malingering, hysteria, and cisplatin. I would, wrap it up in GI causes, central causes, uremia, and medications such as cisplatin. Methods to get rid of hiccups: you can use non-pharmacologic techniques such as drinking ice water, holding breath, breathing into a bag. You can also use acupuncture, and these are some of the acupoints used. You can do acupressure on these points. Pharmacologic therapies. Remember the dopamine and the GABA we talked about earlier. So you have metoclopramide, chlorpromazine, haloperidol, baclofen, gabapentin, pregabalin, and midazolam. I mean, it makes sense because the two main receptors they're working on are the GABA and the dopamine. Each of these has a role in hiccups. So, for example, if I have a patient with renal failure, I would use gabapentin because it's safe. I would give a small dose at night. And I would use metoclopramide if it's just something, uh, like basic. I would start with metoclopramide. And if gabapentin doesn't work, I add baclofen. Now you gotta be careful about baclofen in renal failure patients. You have to give very minute amounts. Don't exceed 2.5 milligrams twice a day. Respiratory secretions is the last part here. The accumulation of secretions within the respiratory tract of a patient around the later stages of terminal disease can become a burden for the patient and the caregiver. It is defined as the sound caused by the oscillatory movement of the upper respiratory airway secretions, along with the expiratory and inspiratory phases of respiration. The classification of noisy respiratory secretions was developed by Bennett, and he further divided this into two types. Type 1, which is predominantly salivary secretions, or in other words, accumulation of the upper respiratory tract secretions secondary to an impaired swallowing reflex or inability to swallow. Type 2 is due to accumulated bronchial secretions, secondary to inability to satisfactorily clear the lower respiratory tract due to weakness or absence of cough reflex. Another classification by Wilders and Minton. Uh, they mentioned the terminology death rattle. And basically, there are two types. There's the real death rattle, which is accumulation of respiratory secretions associated mainly to a decline in the swallowing reflex or consciousness due to non-pathological secretions. Number two is type 2, pseudo-death rattle, bronchial or pathological pulmonary secretions. Example, pulmonary effusion secondary to congestive heart failure or pulmonary edema. This specific category is likely to not respond well to antimuscarinic agents. So we have uh, type 1, and this type 1 is the real one or real death rattle. And then you have type 2, which is the pseudo death rattle. And with type 2, it's basically coming more from the bronchi, okay? And usually is not responsive to antimuscarinic agents. Pathophysiology. Different authors tend to agree the presence of a combination of accumulation of upper respiratory tract secretions in the bronchi and oropharynx due to loss or decreased cough or swallowing reflex, as well as increased M2 and M3 muscarinic acetylcholine receptors, leading to partial obstruction of the airway. The airflow through the secretions produce this characteristic death rattle, which is the result of airway resistance and respiratory rate. Bronchorrhea. Bronchorrhea is also a common cause of increased respiratory secretions, have a similar symptomatic and broad differential diagnosis to noisy upper respiratory secretions, defined as profuse production of the sputum more than 100 ml per day, response to the EGFR TK inhibitors, such as gefitinib and erlotinib. Response to nebulized indomethacin for malignant and non-malignant bronchorrhea. So this is the first time we hear indomethacin, which is an NSAID, used as an inhaler or nebulized for treatment of bronchorrhea. This bronchorrhea has been observed in patients with end-stage bronchoalveolar carcinoma. Death rattle actually is not a serious problem, but it does affect the family more than the patient himself. So how we deal with it? By repositioning, suction. When you do suction, don't go too deep. Don't go beyond the back of the throat here. Okay. Otherwise, you will induce a gag reflex. Reassurance to the family, educational pamphlets help in these situations. Um, This is just show you some of the repositioning tactics here. Pharmacologic is basically anticholinergic drugs. And we have the main ones that uh, are the atropine, glycopyrrolate, and the hyoscine. The nice thing about glycopyrrolate is it's a quaternary ammonium compound, so it doesn't cause hallucinations. Uh, Also, we talked about EGFR TK inhibitor in cases of bronchoray and nebulized endomethacin. These are some of the anticholinergic drugs that we use. Scopolamine or hyoscine hydrobromide, butyl bromide, hyoscyamine glycopyrrolate. Now, atropine is also used. I want to say that this butyl bromide, for example, is a quaternary ammonium compound, so it doesn't cross the blood-brain barrier, and it doesn't cause, hallucinations and typical symptoms of anticholinergic syndrome. Uh, Glycopyrrolate is the same, is also a quaternary ammonium compound. Okay. Key learning points: cough. Chronic cough could be stressful for patients and families. Careful assessment to identify the causes is essential. Remember benign and common causes of cough. For mild cough, start with non-pharmacological treatment. Antitussive agents are available, and the reason for the treatment of choice could be weighed carefully with patient prognosis and medication side effects. Opioids are the most widely available antitussive therapy, especially with cancer patients, but may not be appropriate for in the early disease. Hiccups are assessment of underlying cause and remove when possible. Check medication profile and electrolytes. Also evaluate for gastric distension and reflux. Start prokinetics. Uh, as I said, this would be your first choice here. And PPIs, if indicated. Be aware of medication side effects. For instance, metoclopramide may not be used in malignant bowel obstruction. No response to the aforementioned gabapentin would be your second choice. Secretions. Noisy secretions in the setting of advanced disease are a strong predictor of imminent death, what we call death rattle. Identify the differential as increased secretions in the end of life setting may be related to other causes, such as infection, gastrointestinal causes, or extrapulmonary tumors that may not respond to the most common intervention. Non-pharmacologic interventions such as repositioning and frequent mouth care should be first attempted. Consider discontinuation or decrease of intravenous fluids as they might worsen the secretion. No anti-secretory medication is better compared to another. Also, data showed that pharmacological management might not be useful or necessary. This topic is of a need to further research. Thank you.